Welcome to the AUA Inside Tract Podcast. Today's Inside Tract Podcast explores the Urology Residency Match and is brought to you by the Residents and Fellows Committee. Past committee chair Dr. Michael Ernst, a pediatric urology fellow at the Nationwide Children's Hospital in Columbus, Ohio, sits down with Dr. Simone Thavaseelan, an associate professor of surgery at Brown University, to share their unique perspectives on the Urology Residency Match.
Great. So, Michael Ernst, I'm a current second-year fellow at Nationwide Children's Hospital in pediatric urology and the former chair of the AUA Residents and Fellows Committee. And I'm here tonight with Dr. Simone Thavaseelan from Warren Alpert Medical School at Brown University. Do you want to take a moment to introduce yourself?
Yeah, thank you for having me. I'm Simone Thavaseelan. I'm an academic urologist and residency program director at Brown University. Just about 10 years into practice, I focus on endourology, and I'm also the section chief at the VA hospital.
Great. Very excited to be here with you tonight. So we'll be discussing some work that you've been doing with the SAU, the Society for Academic Urology, on changes to the urology match and specifically preference signaling. To get started, preference signaling was new to the urology match during the 2021 application cycle. Can you describe the reason that it was implemented and the general process that residents and programs went through?
Absolutely. The urology match is a ever-evolving microcosm and ecosystem. And so the Society of Academic Urology is very interested in trying to advance initiatives and innovation within the match in order to make it work for all of us, both applicants, programs, and the various stakeholders that are involved. And so preference signaling was followed very closely after an initial pilot was done by ENT by the executive committee of the SAU. And we followed their data and their timeline. They were very generous in making all of their content open source. And so we were able to understand their process, look at their data, and really consider whether or not it would be a reasonable innovation for the urology match. And certainly this occurred on the heels of a number of other innovations that the SAU had spearheaded. So over the course of the last 4 years, for example, the SAU has introduced through its member task forces, urology match guidelines, virtual away rotations, also a new nationally coordinated synchronized interview release process. Right. And then most recently, the flush day edition in order to allow for kind of switching at the conclusion of that nationally coordinated weekend. And all of these innovations are with the intent to improve the process and the ecosystem for all of the stakeholders involved. And another key feature of the urology match marketplace is the over-application kind of application fever, if you will. This is not unique to our subspecialty, and trends across all subspecialties show an increased number of applications. But with that problem comes a lot of noise on the program end. They're overwhelmed with a deluge of applications, trying to cycle through a lot in a very compressed time frame, which makes holistic review almost logistically impossible. And on the applicant side, they are forevermore applying to more and more programs out of concern and fear over this high stakes outcome of not matching. But that leads to significant dysfunction in the system. Applicants are, again, over applying, and programs can't actually tell what is a credible signal of genuine interest. And clearly in the era prior to over application, applying to a program was, in fact, a credible signal of interest, but it's simply no longer the case at this point. So preference signaling was introduced in order to be a applicant-centered, equitable, fair, and structured method of letting applicants know, to their program or to a specific number of programs that they had genuine interest in that program and that they were applying with intent, if you will. Mm-hmm. And that's how it came about.
Right. And you mentioned that this was applicant-centered. Were applicants required to participate in the preference signaling?
Sure. Because this was a pilot, we made the entire process completely voluntary for applicants. But we went on to see near universal participation from the applicants. Over 97% of applicants ended up participating. Now, there's a little bit of a discrepancy between those applicants who participated in the initial signaling phase and those who went on to submit a rank list. And there usually is some attrition in that process. But overwhelmingly, almost every applicant, despite it being a new process to them, despite it being something that they heard through kind of multimodal communication from us at the SAU through webinars and through email, through social media, they were all able to kind of quite seamlessly participate. And that was also thanks to our partners, the AUA, who helped create the software and the content and structure for this process. On the program side of things, we created the system to be a default opt-in with the option to opt out.
Okay.
And ultimately, there was universal participation with programs as well.
Great. And how many signals did a applicant have to submit? And did they all have equal weight, or was the first signal that you sent to a program saying, you're my top program, number one, followed by number two, number three?
We used a fairly simple design for the preference signaling pilot, which is to say that we had applicants assigned 5 signals, all of which had equal weight.
Okay.
And so there was no distinction between that signal number 1 and signal number 5. We also intentionally selected a relatively low number of signals to be assigned per applicant in order to maintain the signal's value, but also in order to respond to the applicant concern that a lack of a signal when applying to a program would potentially jeopardize their application.
Right.
Our intent here was really to be able to allow the applicant to signal genuine interest, not to dissuade a program from failing to consider an applicant because they elected not to signal them. And so with that, these were non-weighted, non-tiered signals, and they were intentionally kept at a low number. We also recommended to applicants that they forego signaling their home program in order to avoid any conflict with their home institution, and then also to not waste a signal on a program where they had done an away rotation or a virtual rotation, because we felt overall that those really were credible in signals of interest. You know, to spend a month at an institution or to decide to partake in a virtual experience is telling a program, and in some sense it's auditioning to a program, but telling a program that, hey, I really do have interest in your program. I think the other consideration here is also this concept of geographic bias. And you know, a common recommendation to applicants is using strategy around selecting away rotations to demonstrate your geographical flexibility.
Right.
And the kind of use of preference signaling could very quickly, effectively, and with minimal, you know, effort, travel, expense, alert programs to genuine geographic interest or address this geographic bias concern.
Yeah, that was certainly the advice that I got when I was applying for urology residency. You need to do your away rotations not in the same region so that you can get more interviews. Maybe that advice is changing going into the future.
Yeah, you know, I think when we are looking at applications, and when you are faced with you know, an onslaught of 350 applications and approximately a 10 to 14 day period to look at them, you are reading through and wondering, is this applicant really interested in my program? Or if I do offer them this precious interview slot, are they really going to come? And so then you are kind of trying to read the tea leaves. You're reading through the application to look for evidence that maybe they have a distinct interest in your program, or a physical connection by family or by previous training, experience, education. But that is a clearly hit or miss strategy, both on the program and the applicant side.
Certainly. I know you and the SAU have done a lot of surveys for both the programs and the applicants. Do we know how programs were using the signals that they received? And did every program receive signals?
Yeah, in terms of the distribution for signals, first, every program did receive a signal. The average number of signals received by a program was 19, but there was a fairly wide range, anywhere from 1 to 62. So if you put yourself in the shoes of a program, you can imagine how the value of signals very much depends upon the number of signals you might have received. If you received very few, that might mean that those applicants are clearly very interested in you. Conversely, if you received on the order of the average, around 20, that in general is about 50% of the number of interviews that the average program is offering. So that might allow you to focus on those applications. But when we did query programs about how they used signals in this cycle, what they told us overall was that a majority incorporated it into their initial application review process.
Mhm.
And then a second approach was using it as a tiebreaker for interview offer decisions. And then we saw that very few programs used it as a kind of requirement screening tool, an issue we were purposely trying to avoid by keeping a low signal volume. And then we also saw, I think as expected, that many programs weren't necessarily using this in their rank list decisions because the process of interviewing gives you so much more additional interpersonal information that largely influences those decisions downstream from the process of interview offer.
Mhm. And it sounds like as an applicant, sending my signal would, as it intended, indicate a genuine interest in the program. And then hopefully that would be considered when making decisions for who to interview. Are there some programs that received signals but didn't use them at all during any point in this process?
Yeah, absolutely. We did see when surveying programs that around 12% did not use them at all.
Mhm.
I think that comes out of the nature of the fact that this was a first-time pilot. And
Mhm.
so as a program and program director, you're certainly faced with what is a new metric in a process where there's kind of a fairly set standard number of metrics, and each program does this a little differently, but they might value and weight certain metrics in some sort of scoring system for their application review to make interview offers. And so, as is intended, we wanted programs to use it as one of many metrics, certainly not the sole, and not as a screening to get an interview. And I think that's how the majority of programs did, in fact, incorporate it.
And this past year, when we piloted the program, we were also doing entirely virtual interviews. Foreseeably, in the future, there may be a return to in-person interviews. Do you think that would change the way the signals are used? The investment from both the applicant and the program in terms of doing a in-person interview seems to be more significant than a virtual interview invite.
Yeah, I think that this signaling system overall has so far only been used in the virtual setting, both at the ENT, with urology, and then with the 4 programs that used it through a pilot with ERAS, which was internal medicine, prelim and categorical, general surgery, and dermatology. So it has not been used yet in a cycle with in-person interviews. However, I think the goal and intent of preference signaling is to be really that gateway process of moving from applications to interview offers.
Mhm.
And so I think the interview process is interview and ranking process is much further down the line. And so I think that it's likely to behave in a similar fashion with in-person visits in terms of when it is valuable to programs is when they're making application review decisions.
Mhm. As an applicant, and I think the data was that half of all the signals went to 25% of the programs. Obviously, we want to be signaling programs that we have a genuine interest in. That's the purpose of it. Would it make sense for me to send my token to programs that may be a reach for me to potentially get that interview, get my foot in the door, and then have that more holistic review after the interview?
That's a great question, to which I would say that the data does not exist to answer it effectively. It is being analyzed by ERAS in their pilot to evaluate whether using a strategy of sending your signal to a reach program increases your likelihood to interview at that reach program.
Mhm.
What we saw in our survey data of applicants was that somewhere around 80% of applicants, in fact, used it as that intended genuine interest, and about 25% used it in that reach situation. I think the best advice to give applicants at this juncture is that the goal is for genuine interest. So really focus your attention on selecting your signals with that goal in mind. But we acknowledge, and we saw in our data applicant response-wise, that signals 1, 2, and 3 did have a higher rate of interview offer, but signals 4 and 5 did not. What I was not able to analyze with this was signals 4 and 5 in terms of which programs they went to, were those reach type
Yeah.
of programs.
Mhm.
Certainly when I looked at that
Weighted.
initial data, caught my eye,
Yeah.
but I can say that we haven't been able to analyze that.
Okay. And from the survey data, do we know, was the preference signaling system, were urology resident applicants satisfied with how it worked this past year?
There were fairly high rates of being satisfied with the overall program, meeting its goal of being a fair and equitable system. Certainly high rates of recommendation that we would continue it as opposed to, move away from it. And a little bit of a discrepancy on the applicant side as to whether the process, if you will, benefited applicants or benefited programs more. There was about a 50-50 split on that. But that level of satisfaction overall was mirrored by the programs as well. Overall, I think it was seen as of value as one of many metrics in this process.
Certainly. And I know other specialties, we talked about ENT kind of starting this initially and then sharing their data that prompted urology to pick this up. But we're still one of the early adopters. Going forward, orthopedics and OBGYN are potentially starting their own signaling processes with maybe even waiting signals or expanding signals. Is there any plan to increase the number of signals that urology applicants can use or develop a waiting system?
Yeah, great question, because I think you hit the nail on the head in that we were certainly an early adopter of this phase, but in the cycle of 2023, it's going to be widespread. Over 19 subspecialties are going to be involved in preference signaling. And two that you mentioned, OBGYN taking a tiered approach with a total of 3 gold signals and 15 silver signals, so a 2-tiered weighted approach. And orthopedics pursuing a total signal count of 30 is a very different pathway to go down, where the number of signals are no longer deliberately kept low in order to maintain value, but instead are more closely mimicking what a potential cap on applications might look like. Now, it's not a true cap. There's no hard and fast rules to this, which is to say applicants can still wildly apply and can still certainly over apply, and they will over apply. But these subspecialties are going to be able to potentially use this more as a mechanism to, in fact, screen for interview. Now, is the SAU considering that? The SAU is very closely monitoring all of this and are watching what other subspecialties are doing. The SAU is part of the OPDA, the Organization of Program Directors Association, where these types of conversations are occurring across subspecialties to learn from each other and figure out what is your rationale, what does your subspecialty do, and how do they do it? How do they communicate across all stakeholders? How do they gain consensus to make changes, in a process where multiple stakeholders are involved, be it ERAS, be it applicants, medical schools, program directors? There are a lot of parties involved in the Urology Match. And so I think the goal of the SAU is to seek more information, both from stakeholders and other subspecialties, in order to make an informed decision about how we might be in the process of kind of an iteration of the next year's cycle for preference signaling, but also other processes in the match. I think it's really key to think of the match as a living kind of ecosystem that is really subject to change for the better if we can organize ourselves, if we can lead, and if we can have transparent and open communication to be able to make changes and then investigate and evaluate them, assess them for unintended consequences, keeping kind of both transparent communication and then the other North Star of equity and the need to diversify our subspecialty as values that guide the changes that we might undertake as a subspecialty.
Certainly a lot of factors there to consider in their impact on preference signaling and vice versa, how preference signaling may change the diversity efforts that we've started within urology. But this is really just a small part of the greater match process, application process within urology. And certainly as things develop going to the future, there may be changes to the preference signaling process or the match process. Where can applicants go to get the most up-to-date information? Because I know oftentimes rumors will circulate between applicants, or there's some message boards online, but where can they get like the real facts, timelines, information?
Yeah, the best information is going to come directly from the Society of Academic Urology. Okay. They work in partnership with the AUA. The AUA runs and executes the Urology Match. but the SAU leads and directs the match. And so they maintain a very close relationship and communication. Their websites mirror each other, and any changes go through both of these websites. And so that is the ideal place. And then after that, there's also the local mentors and sponsors that students might be working with, their clerkship directors or program directors at their universities and institutions, who are receiving information directly from the SAU and the AUA about changes. And so once these types of decisions are made, the SAU kind of takes a viewpoint of communication via email, of communication via the website, and also through social media in order to reach applicants and programs. I think the other thing to kind of keep in mind is the outcome that we were trying to assess also in terms of preference signaling is, does it change the likelihood that an applicant gets an interview? Mm-hmm. And what we found overall was that the overall interview rate for the urology 22 cycle was 12.5%, and that the rate of interview for a signal program was up to 51%. And so there was a nearly fourfold increase in the likelihood of interview for a signal program. I think that is information that those who are counseling medical students can really quite comfortably share with students and say that this is what the data showed last year. Right. It was also very comparable to the data from ENT, which is a very small competitive surgical subspecialty, much like our own. And so I think that suggests that if we maintain a signal value of 5, that's very reasonable advice to give applicants in terms of what they could expect for benefit from signaling a program.
Yeah. And that you said a non-signaled program interview rate was around 12%. And that 12 might even be a little high because it's including all those away rotation programs and home programs. Would that be correct?
That is correct.
And so it might even be more than a fourfold increased rate. Well, that's great. Preference signaling certainly sounds like an important change and something to keep an eye on. But really, as we said, it's just a small part of the urology match process. Are there other changes that the SAU is looking at to adopt into the future?
I've spent a lot of time thinking about where does preference signaling fit within the whole process of the match. Because I think there are some subspecialties who are on the leading edge of innovation of addressing what I think is characterized as dysfunction between the undergraduate and graduate medical education transition. And I think this dysfunction is significant, it is long-standing, and it is difficult to change because in reality, there's no single entity that has full authority over the complex ecosystem of the match in order to promote reform or improvement. And so it is just but one piece. And I think the recent Council on Physician Accountability developed a committee, the URGC, that developed a number of recommendations for subspecialties to really assess and evaluate if they wanted to meaningfully improve this transition. They came up with somewhere on the order of over 25 recommendations. And this portion of preference signaling just fits into one of those areas, which is the application and the interview process. I see multiple other areas or points of leverage to address this dysfunction. And I think the dysfunction is multifactorial. It's the issue of a disproportionate amount of attention paid, on the part of programs towards finding and filling these residency positions, rather than focusing our efforts on training, competence, and readiness for residency training. There's high levels of stress in the system for learners and applicants and for programs, throughout the whole process. And there's a bit of a mismatch between what, the goals of the applicants and what programs are looking for in order to really meet that ultimate goal of providing well-trained urologic surgeons to provide high equitable care to our patients. And there's also some mistrust because there's a lack of transparency in the system. Students don't know exactly how the sausage is made, if you will, behind the curtain. They don't know how applicants take their data and how they use it to determine interviews or make decisions. And so there's a lack of transparency on how resident selection really occurs at individual programs. And there, I think we're well aware of an over-reliance on USMLE and the absence of valid, trustworthy measures of a student's actual competence and clinical abilities to be an outstanding resident, to become a well-trained independent urologic surgeon. And there's clearly cost associated with this on the order of thousands of dollars.
And time and cost in a lot of the different time points.
Absolutely. And there's also this component of individual and systemic bias baked into the system, and inequities, which I think we're well aware of the fact that the need for diversification of the urologic workforce is significant and the gap is tremendous. And so I think that's the backdrop of the dysfunction that exists. Now, what I think it takes to be able to address all of these is a sincere willingness on the part of our subspecialty organizations, our professional organizations, to organize ourselves, to lead, to create coalition and consensus across programs, because we value autonomy in so many ways, within US culture. And so program autonomy is important, but organizational process depends and relies upon leadership, clear values, a willingness to make change, and then assess it, in true fashion of quality improvement, like we would apply to a clinical problem of plan, do, study, act. And so I think we've been able to show from a point of view of this preference signaling pilot that this was a proof of concept of that process, and that we could use that momentum to apply it to other areas of the match.
Absolutely agree. And I think the point you make about transparency in the system is very important for the applicants. Because it is a scary process for them to go in, and their best resources are oftentimes the people who just came out of it, who are really just getting a glimpse of what may be happening at individual programs. And so I certainly commend you for the work that you've done with the survey data and presenting it both at meetings and discussing it tonight, trying to increase that transparency a little bit about how the process is working.
Sure. One other byproduct of this process is that now we have a fairly reliable method to survey applicants when they submit their rank lists. We have an opportunity with every cycle and every cohort to ask the important questions. When we did this survey, it was not about preference signaling only. It included questions about virtual interviews, virtual away rotations, our interview process. So we have an opportunity to gather data every year now in a reliable method through the AUA. I think the other thing that we've learned through this process is there, again, are pockets of innovation. And so I think the field and subspecialty of OBGYN has a fairly robust grant-funded set of initiatives to improve this process. And so, for example, they're developing an alignment app or tool where they will have the ability to have their applicants look at their ERAS their ERAS application, look at the various components of it. And on the other end, programs are putting in their information about what they weight. How do they make decisions? What do they value? For example, number of research projects, work in volunteer and advocacy. And that will allow the applicant to use this app and assess these programs. I think when applicants are faced with over-application, they're throwing approximately 80 darts out there, and approximately 350 of those are landing on a program's desk. They're doing this apart from that high-stakes risk of not matching, because they also cannot tell which programs, in fact, align with their needs, interests, desires, or goals. They're using the websites, they're talking to people, they're hearing what other folks might have to say about the reputation of that program. And then clearly they're doing away rotations, but that's limited by a number of issues: scarcity, a free-for-all application system, and cost. And so there is no method, if you will, for them to, in fact, query programs and determine what would be a good fit in order to stop the madness associated with the application overload. And so I think that I look forward to seeing, the results of that tool for OB, and I think it's ingenious. So I'm hopeful that we could start to think along those terms. I think the other kind of unique issues out there is charting the outcomes of the match through the NRMP. Yeah. We don't participate in the NRMP, right. But most other subspecialties do, with a couple of other exceptions, similar other small subspecialty programs. And that also provides data back to applicants to be able to look back and say, well, if these are my numbers and stats, how do I fare applying to this kind of a program? And I think that level of transparency is also critical if we want to be able to tell applicants, listen, you don't really need to apply to 80 programs, but you need to be able to pick that 30 or 40 that really makes sense for you.
Absolutely. And the program, hopefully with 300 applicants sitting on their desk, can pick out the 30 to 40 that they should be interviewing who might be good fits for their handful of spots.
These are precious resources to bring someone in for an interview. And more likely than not, that person's going to end up on your rank list. And ultimately, I'll say as a program director, despite all the effort that I might put in my faculty and certainly my residents into the recruitment process, I think you still don't know what you really have until you have that trainee on site and they're taking their first night of call. They're presenting that patient at 2 a.m. And then you realize, okay, I know what we're dealing with here. I know what kind of a clinician we're developing here. And so, despite all the time and effort, it's still a little bit of a black box to go through this roll your dice urology match process and see what happens on the other end.
Absolutely.
Now, despite all this dysfunction, I still firmly believe that a match is better than no match. I think that despite the degree of kind of systems-based issues with the match, that it's still a superior set of processes than what existed prior to the match.
Yeah, just the fact that there are some problems, we'd be trading these problems for very different and maybe significantly larger problems without a match, and I think we can see that.
Yeah.
I think that wraps up our discussion on the urology match, specifically for preference signaling. Do you have any other final thoughts?
Yeah, I'd say that urology is a great field. And so, if there's applicants listening to this, you've chosen really wisely. And I think one of the best aspects of our field is that it's a small community. And so I'm an academic urologist, but when I graduated residency, I had no idea I was going to end up becoming an academic urologist. And so a couple of years later, I've met a lot of people across the entire country, and I'm still in touch with those folks that, I was on the interview trail with, and that I trained with. And so I would tell applicants, you've chosen well. It is a wildly stressful system. All of you are far more accomplished than certainly I was when I applied. But you have to roll your dice and see what happens. And I'd say to programs out there that I think urology programs getting together to establish coalitions and consensus allows us as a field to row the boat in the right direction. And so I think if we center ourselves on the values of equity and transparency and centering ourselves on applicants, then we make changes in ways that we study in order to improve the process. And I think that's what is called on us to do as academic leaders. And I'm hopeful that we're up to the task.
Thank you very much. And I'm very appreciative. And I think us young urologists and applicants and current residents are very fortunate to have strong leaders at the SAU, such as yourself and many others who are working at this and thinking about these big problems and trying to solve them even small steps at a time. So again, appreciate your time and expertise on this topic. I know it'll be very useful for students who are applying for the Urology Residency Match this year.
Absolutely. Thanks for having me, Michael. And I wish you well on your own academic journey, because I think you are a rising star. And so keep at it.
Appreciate it.
This has been an AUA Inside Tract podcast brought to you by the Residents and Fellows Committee. Check out the AUA University podcast for weekly episodes on the latest clinical updates and advances in urology. For more information about the AUA and membership, visit auanet.org.